Everyone, I see some tired faces, so I'm going to do my best to entertain you as best I can. I'm not writing any checks, though. Okay, we're streaming, right, so I have to stay here. I tend to go walkabout, but I'll try not to. Okay, my favorite slide that these days, nearly every talk I give, I start with, because it explains, in a nutshell, what we're doing. Can everyone hear me okay? Okay. So this is a study that was published in a reasonably reputable journal, PLOS ONE, just last year. And I won't bore you with the details, but they effectively managed to, and I'm worrying about causation and correlation now from a while ago. I think this is tighter than that, but we'll see. But effectively looking, it's a UK-based study, hospital trust groups over there. And effectively they looked at a pretty easy indicator, mortality. Okay, it's unarguable. And they looked at emergency department admissions into trusts that had a research active culture. I'm not going to bore you with how that was measured, but let's say a set of trusts that had a research active culture and a set of trusts that did not. And they looked at one outcome, death. And quelle surprise, those hospitals with a research active culture had lower levels of mortality. I'm not going to go into great detail, but the general message is, and the nice way of putting it is, patients have much better, and they controlled for staff mixing and all the usual stuff. Patients have much better outcomes in care settings with an active research culture. I don't think it's probably a great shock to people in this room, but it's a nice little simple story to set the scene, and that's what we're about in terms of the Health Research Board, working with the Department of Health, etc., in trying to get this integrated properly into the Irish healthcare system. Now, could I have a bottle of water there, please? Kind of thinking about the kind of research infrastructure. I'll use the bottle. It's easier. I tend to rove. That's a minute. Cheers. Yeah. I can use that. Okay, thanks. Our kind of, I suppose, our infrastructure and our capacity to put research into practice maybe 10 to 15 years ago probably didn't consist of a lot more than the actual patients themselves. Okay, I want to do this very quickly because I want to get on to the real evidence piece. We've made some pretty rapid progress just in the last few years, and to fill out that picture, I'm not going to go through this in great detail here today, but just to give you a little view of the kind of system we have now. Very simply, I would say the stuff to the yellow side of the diagram, I can't do my left-right thing, so I'm facing you here, but the yellow side of the diagram is kind of the physical facilities, okay, the clinical research facilities in our major teaching hospitals, our academic teaching hospitals, Cork, Dublin, Galway, and so on. Over on the blue side, we have our kind of clinical studies, clinical trial networks, the biggest one being cancer, but there are several others there, as you see, in perinatal care, in stroke, in primary care, actually, one led out of here as well. And critically sitting in the middle are two of these kind of gel components, I call them Declan Devan's trial methodology research network, and this sort of shared service entity called the Clinical Research Coordination Ireland. So this really has fallen into place quite rapidly, much of it actually over the last few years. I think the Taoiseach opened the facility here in the hospital just about a year ago, I think. And this stuff means something for people. It's nice to put up slides with fancy pieces of infrastructure and p-values and everything else. But if I could just very briefly, I'll do it rapidly, talk about a few people here. Paul Lamb in the middle here told us a pretty dramatic story at an event we ran about a year ago in the Gibson Hotel in Dublin. He was driving through the Dublin Port Tunnel. Halfway through the tunnel, felt a massive pain in his arm and his side, and basically he was having a huge stroke. And he just about managed to get his car to the other end of the tunnel, call his wife, blacked out. Next thing he woke up in hospital. He, under prior treatment, quite frankly, in Ireland, if it had gone back just a few years, would have probably, if he had survived, would have had quite a significant disability and might have had to be looked after 24/7. Instead, he was rapidly taken to a stroke unit, given thrombolysis treatment straight away, but more importantly, a device inserted effectively through a blood vessel in the groin, passed up, effectively, I'm going to put it bluntly here, grabs the clot and takes it out. Okay, it's called thrombectomy. This was developed here, trialed here, Cochraned here, and put into service here. Okay, and this is normal treatment now for acute severe stroke in this country. I mean, it's such a dramatic, simple story about what can happen to you in the case of severe stroke. And you know, think about it. Think his life. He's back at work 6 weeks later instead of being disabled. That's a brilliant outcome for him. And it's a brilliant outcome for our health service and our taxpayers. This is the kind of thing we need to do, with much better use of our resources. The man well, on my side, it's to the left here with the hat, is Sean Malone, also from Westport. Exactly the same story, collapsed in his kitchen, massive stroke, back being a chef now in Westport. On the right here, you'll see William Power, an eye surgeon with Patrick Godfrey, almost blind in one eye, almost are heading for blindness in the other eye, with all the disability that entails, with the genetic condition of basically the epithelial cells on the cornea of his eye would cloud over and effectively block vision. And actually, Martin Klein's out in DCU, and his team grew using stem cells, corneal epithelial cells, grew them up in the Irish Blood Transfusion in the eye bank, actually in St. James. And William Power here transplanted them in. And that lower picture of him there is just from about 6 weeks ago. And he's back making himself a cup of tea, making his own food. Before, he was looking at like full-time care. Okay, so this is fantastic progression of research and evidence, I suppose, into practice. And one of my favorite stories, the two ladies at the bottom here, sorry, I'm missing the picture of Anne-Marie, but if you're given if you have certain types of early stage breast cancer, you have your surgery. And the big question is, do you need follow-on radiation therapy or chemotherapy? Because we know that I suppose practice was everyone got it, okay? Painful, expensive, arduous, expensive to the health service, awful for the individual in question, in the full knowledge that at least half those women didn't need it. But we had no capacity to differentiate the women who didn't need it from those who did. So what did? We give it to 100%. Okay? That was the care up until a few years ago. I'm not going to go through every aspect of this, but effectively a test became available, a genetic test, one of the most marketable ones, I suppose, is Cotype DX. Effectively, it analyzes the expression of genes in the breast tissue, in the cancerous tissue, 21 gene expression. In very simple terms, it produces a score, and this score is an indicator of your likelihood of recurrence or not, and actually becomes then a differentiator. This is a beautiful story of personalized medicine. And the two women on the last slide there, Amy on top, I think, had a low score from this test, and it was possible for her to make the decision together with her oncologist not to proceed, to make a good decision, an informed decision, to not have follow-on chemotherapy and radiation therapy, whereas Anne-Marie below had a score of 25, and that was like highly likely recurrence. So that was the logical move, was to proceed to chemotherapy. And this stuff matters. If you look at this is data from a clinical trial, TAILOR-X, which is looking at this test in Ireland, first site outside the US to do it. So people like John Crown et al., who'd be well known to many people here. But in every blue bar you're seeing there, St. Vincents Matter, I think Galway, yes, there it is, the third one. The blue is the people who had the cancer. And in the old system, they would have got, after the surgery, all of the blue would have gone on to radiation therapy or chemotherapy. Thanks to the test, you can see the numbers in the sort of red auburn color there. So the gap between the two is all the people saved that treatment. So there's all those individuals, and this is running into millions over the sample checked here. It's just such a beautiful example of good use of science and practice, research and practice, to target health resources for a massive benefit of individual patients, but also population, and particularly at taxpayer level. We're going to bankrupt ourselves if we head to 17, 20, 25% of GDP in healthcare. It's not going to be possible. So we need better and creative tools like this. So I wanted to just give you a very quick view of that, knowing I had the graveyard slot here. I wanted to hopefully tell a few human stories. But I want to go on to real-world evidence. And, I mean, you stuck it to me. I wasn't really sure what it was. I think I do a bit of it, but it was the first time I suppose I had to really kind of think hard about it. And I've used a kind of corny definition for myself here in italics at the bottom. I don't know if you agree with it or not, but I don't think there is a standard definition. But I'm taking it as the kind of evidence that's coming from regular care and practice that combined together can produce an improved outcome, such as the type of stuff I showed you before, but potentially in other situations. Okay, but you'll have noticed from what Mirish had to say, and et cetera, we have a data issue, okay? And all that progress I showed you, and we are making significant progress, and we will continue to do so, but I think we have a major gap that we need to address if we want to really push this progress on, and that's centering around this issue of data. And part of that is obviously what we're going to refer to as real-world data. So I'm going to talk to you about, Mirish mentioned a nice acronym, and I'll come to it in a moment, called DAZZLE. But there are lovely examples elsewhere. If I look to the west of Scotland, Coronary Prevention Study. Does anyone in here know this study? Okay, good, I'll explain it then. So this is a study done in the, as you might guess, in Scotland a number of years ago. 6,500 men. This is a coronary study, statins, the drug used to treat, counteract cholesterol, etc. And the usual randomized controlled trial type stuff, but there was a 10-year follow-up after the main study where the records were linked to hospital discharge records, the cancer registry there, and death records. And they were actually able to, in that 10-year follow-up study, were able to effectively calculate that for every 1,000 patients treated with these statins, there was a roughly 1 million saving. That's in euros, you'll notice here. I think it's 750,000 sterling at the time, for every 1,000 men treated as a result through that system. Only possible because of the capacity to link those completely different data sets, okay? Totally different scenario over in Wales, the electronic cohort for children, WEC, I think it's called. We all know preterm early births are on the rise, lots of reasons for that, etc. Anecdotally, and more than anecdotally, it was known that premature babies have a lot of problems with lung function, okay? So this study here, 300,000 babies managed to get birth records, inpatient admissions, and mortality data together over roughly a 10-year period, you can see there. And basically managed to establish that the more premature the baby, the more severe the respiratory issues in early childhood. And in fact, it's not a linear relationship, but in fact, they showed also that even if you take a baby born at 39 weeks, okay, so almost there, but a 10% increase in respiratory issues in early childhood. So that's got major implications for obstetric care, okay? Thanks to the ability to pull these different data sets together. But we here in Ireland struggle to do this, okay? So here's some corporate spin from me, HRB words, in terms of what's in our plan. We've committed to advancing the exploitation of data and health research in our strategic plan. Great stuff, lovely corporate statement. But I'd like to give you some evidence that we actually are, okay? We specifically laid out an action, and this is one of the things that will come with the check, which is to promote the secondary analysis and deeper exploitation of existing data sources in order to deliver high quality, high impact evidence for policy and practice. That's quite a statement. I don't think that's been in any of our previous, certainly as explicitly as that. And more importantly, we said we will support other activities that enhance the national capacity for access, I'm missing a word here, storing, sharing, and linkage of routine, administrative, and/or research-related data sets. And just read that again, everyone, please. Okay. Enter this. So we said that a year ago. We've already produced and published this report here. Could I get a show of hands here? Who is aware of this report's publication? Okay. We have a long way to go in getting this information out there, don't we? Yeah. I've had a lot of conversations with Mirish on this, a big job of sort of building support. I'm going to tell you a little bit about this. So it's quite a mouthful there. Proposals for an enabling data environment for health and related research in Ireland. How am I doing on time here? Am I okay? Good? Okay. And all good things should have a sexy name, so DAZZLE is what we're going with, okay? Because you'll remember that. Okay. Now, this is the kind of data ecosystem in which we live, and I suppose the various stakeholders coming at it from a health research, I suppose, viewpoint. And you've got the Department of Health there, Department of Enterprise, various agencies, Department of Public Expenditure and Reform, the HSE, Eugene, etc. Legislation, the Data Protection Commissioner, I'll come back to that. Central Statistics Office and so on. These are all the players engaged in this space, okay? I think most of you will be quite familiar with this, and obviously internationally as well. Our landscape here, I suppose we turn this on its head and see that our data is in fact a major asset. We don't have a lot of oil, we don't have a lot of land mass, etc. But one of the things we have is, I suppose, our intellectual capital, and trying to turn that data into a true national, those data sets into real national asset. Think, what kind of ones do we have? Murish mentioned it earlier, the census. Loads of administrative data sets. We have routinely, he says in inverted commas, collected health data sets. We just heard loads of them from Eugene, etc. a moment ago. We have disease registers. There are brilliant cohort studies. The Growing Up in Ireland is mentioned. We have TILDA, etc. And as mentioned earlier, I think HICWA have catalogued upwards of 100 specific data sets. I know them very well. 5 of them actually are part of my other job in the HRB, is maintaining 5 of them. But there are considerable challenges, okay? Some of them are shared in other countries, but some are unique to Ireland as well, or certainly experience more. Nicely and very delicately put here, uncertainty around the legal frameworks and how to interpret the legislation. Significant concerns around data protection. Understandably, a culture of caution. And it's one of the things, I was at a round table, Carlos, I don't know how to pronounce this properly, Modas, the Commissioner for Research and Innovation, last Friday in Cork, and I was trying to flip the balance a little bit. Right now, there's the culture of caution completely outweighs the culture of innovation and trumps it every time. And we have to, trump is probably a really bad word to use at the moment, trounces it every time. We have to come back to that, I think. There is a significant skill need, and we have a deficit of these skills at the moment, certainly the kind of quantities. It's brilliant that we're having this kind of debate here today, because it's the kind of place that's going to at least produce some of the pipeline, stepping into human capital pipeline will step into this gap. And we know about the identifiers and the link stuff. It is quaintly put here, it can be difficult to get consent to access and share personal data. I'm sure some of you have been through hell getting to this, okay? And it's quite interesting. How many people have heard of care.data? Raise your hand if you know about care.data. Not that many. There was a major project in the UK in the National Health Service a few years ago, which basically was collecting all the records from within the NHS and dumping them effectively into a central location for use in further care research, etc. But it was one of those classic cases where the technology and the zealots got ahead of public support and general process support, and it died. In fact, it was quietly scrapped in July. It's well worth something, because you should look it up and look at some of the newspaper articles, because I think it's a salutary lesson for us about how we have to step, what was that word, intentionally, but cautiously and carefully and in a very determined manner over the next few years. But the lady whose report effectively came at the time it was killed and came with a new view on the whole protection area and data, etc., Dame Caldecott, did publish a very important principle. I think someone alluded to this earlier. The duty to share information can be as important as the duty to protect patient confidentiality. And that's really difficult, and I think it's going to take us some time to get our heads around this, but there are cases when you're talking about the public good where we're going to have to make a choice. Okay, enter DASL, okay? Data, access, storage, sharing, and linkage, hence the DASL, okay? That's where the DASL is coming from. We undertook a piece of research effectively within the HRB and produced this report, and it strips it into 2 layers. I suppose the identification of the infrastructure and services needed, so the actual kit and some of the governance and everything, and the legal and technical environment in which it operates. And really, this is the important picture. Can you see that properly? I'm going to make sure, actually, if there's a mailing list from this today, I would like to get a link out to everybody of this report. And there's a lovely short version where you can start with that first, and for those that are still interested, move on. I think people in this room, certainly many of them, need to read this report. Okay? I know I would say that, but It's critical. Let me break this down just a very simple way. The top, is there a pointer here? Yes, brilliant. Thank you. So, and I know I have to try, we have many online? Okay, for the people, I'll do my best here. For the people online, I'm actually going to the very top layer here, which mentions, I think, God, my own site is going, terrible problem being in your 40s. Information governance, research ethics, project approvals board. Effectively, that top layer is all about kind of the oversight piece, okay? That's the easy way to put it. Putting together a committee or set of committees or whatever else that have the capacity to take in proposals for this kind of data sharing and linkage, and to oversee it in a trustworthy, trust-building, confident, capable manner, okay? So I suppose you could look at our ethics committees and system today and think about a data governance analog or extension of that, but it needs to work really well if we're going to build confidence and get trust and not have the kind of experience with care.data that I just talked about at the moment in the UK. Sitting in the middle is the actual infrastructural piece. So there needs to be a trusted third party where data from different sources, I suppose, excuse me, I probably jumped ahead. I'm talking here about the type of model in which we can take potentially identifiable data, health data from people, linking to other administrative data sets and put it together to bring out the kind of findings I talked about in the West of Scotland coronary study or the Wales baby cohort or iterations thereof, okay? Trusted third party where data can go safely, be potentially pseudo-anonymized if that's necessary, you know, to break the link. There needs to be a data linkage service. There needs to be a safe haven, which is the type of environment where this stuff in a locked down environment, both either physically or virtually. I mean, it might sound like we're being really cautious in this stuff, but by God, do we have to be really careful. We have to do this really well, and we have to do this in a way that we can demonstrate so clearly to the people whose data this is, that this is being overseen properly in a really rigorous and proper manner. And there's a bunch of, we've called it here, research support unit, we think it needs to come with this, which has a clearance function, disclosure, control, and dissemination. There's a whole lot of skills associated with this and a human capital need that goes with this. And critically, it's very easy to look past, it probably needs to be a little bit more colourful at the bottom there, a public engagement function within this model. Because we need to be telling people about this stuff. If you look at the climate that's out there at the moment, we have a general, the GDPR, the Data Protection Regulation, coming down from Brussels in May 2018. It's a lot better than it was looking at one stage, but it's still pretty tight, and it's going to put very onerous restrictions on us in places, and we've got to be able to, I think, whatever legislation we put in place, it's winning the support and trust of people to share their data comfortably, and that's so important here. A key function of this infrastructure is going to be that public engagement, telling people the stories. Why is this important? What is your contribution? Why you should share your data? I said we need some legislation. I think we probably need some simple, basic legislation. I would not get it overly complex, particularly in this kind of what we call sensitive data. Oops, hang on, this way. But with that baseline of simple, what I call enabling legislation, probably the most important thing is the layer of oversight and governance that sits on top of that. Because no matter how good your legislation is, it's not going to have a little piece of text that fills every situation that's going to arise. It's not going to. We're getting into a massive world here that's very dynamic. And there's a beautiful quote here. A guy called Graham Laurie, Wellcome Trust investigator, is a lawyer based in Edinburgh. And lessons learned, I do want to stress this, lessons learned from the international literature suggest that special legislation will not necessarily result in good or better governance. Rather, what is needed is a robust authorizing mechanism which can deliberate not only on the conformity of research projects to existing legislation, pause, but also on research projects' conformity to guiding principles and best practice which help navigate the spaces in between legal requirements. It's a lovely piece of text that really gets at, and that's what this layer at the top here, this governance structure that we need sitting over this, that is going to have the skills and capacity to acquire and maintain the trust of people in allowing us to do this kind of data storage, sharing, and linkage, which is really going to, I feel, build out the next level of research in the health space. And actually, I think it goes much further than health. What we talk about here is true of the fuller system, integrating back in with the CSO and census and so on. Okay, so that model we've talked about, basically, and I'm stuck on the safe word, but safe projects, safe people, safe data in a safe setting with safe outputs. You might wonder, I probably should have mentioned disclosure control. It's just to make sure when you've done all your linking and everything else, can something leak out that can lead to the identification of people whose data is involved? You just cannot have that. It'll just blow it wide open unless we really are on top of this. Benefits, better and safer use of existing data. It's very expensive to go out and get primary data every time. We need to, we would be much more efficient if we can crack this. Because a lot of the data that we need very often is already there. It's the ability to go and get it and link it together. And basically an evidence-based for better government, better health and well-being. You heard Mersh talk about this, better enterprise and better civic society. Others have done some of this already. I'm not going to go through all of this, but if you look at the central channel here, we have some really good relationships at the moment, actually, with Sale in Wales. We have a really nice facility and have been at this about 10 years now, and SHIP in Scotland, and indeed NISRA in Northern Ireland. And we even have an offer at the technical level that they're willing to give us, I think, some of their, basically the code they've built to do this stuff for free. So we really have some, I think it's promising. I think it's quite exciting. So in conclusion, I think we have, with the DAZZLE model, I need to get this report to everyone in this room, read the executive summary at least for people who are into data here, to frame a workable solution for safe use of data in Ireland as a way of adding value to the national data infrastructure. This kind of links back to Mersh's point earlier, how it connects into the larger picture. As I said, I think we will, when the data protection regulation comes, we're going to require some small pieces of legislation that allow us sort of localise that in Ireland a little bit. But I am stressing, maybe for about the 20th time here today, it's the governance and trust process that we must build and operate in a most robust manner, is what I will say. And I suppose part of what I'm doing here today, we've been on this journey now for a while, for a number of months now, but the very show of hands showed me earlier we have a lot of work to get this model, or a variant thereof, disseminated amongst communities such as this, so people are aware what needs to be done. And if we crack this, built on the kind of infrastructure I showed you earlier on, there are very strong reasons to believe that we can push the kind of health spend we have in this country to much more effective use. Thank you very much.